Good evening, everyone. My name is Ben Wakefield, and today, this evening, I'll be hosting another BASH webinar. We have two excellent talks. The theme this evening is traumatic head injury and cervicogenic headache. These are commonly encountered in complex headache clinics and something that I often ask patients about, and often it's relevant if present. I'm going to hand you over to our first speaker now, Lieutenant Colonel James Mitchell, who's a colleague of mine in Birmingham. He's recently been appointed as a headache consultant, and he's also jointly qualified as a rehabilitation consultant. And today he's going to talk about traumatic brain injury. Over to you, James.
Thanks very much, Ben. Can I just check that you are now seeing the slides?
We can see the slides, yeah.
Brilliant. Hi, so James Mitchell. And thanks to Ben for the introduction. So on the military side, I lead the military's traumatic brain injury service, and in particular our mild traumatic brain injury team, where we see about 150 to 200 soldiers with these injuries per year in our rehabilitation centre at Stamford Hall. Those are injuries across all three services and across the whole of defence. So they come back through wherever they've been, back through to us just outside of Nottingham and Loughborough. We receive our more severe injuries into Birmingham, which is where I work with Ben, and he very kindly allows me to host a military and complex headache clinic there. And I've also got research interests where we're running the MTBI Predict consortium, which is a kind of a Midlands based consortium with Nottingham and Aston, but also reaching out wider with Imperial, where we're recruiting about 700 people with these injuries to follow prospectively over the next few years. So I'm talking to you this evening about mild traumatic brain injury, what it is, and then kind of highlighting probably how I and my service take an approach to it. And then I'll be focusing in a bit more on to post-traumatic headache, which is, as you'll see, the commonest sequelae. So traumatic brain injury in and of itself then is quite simply defined as kind of a structural functional injury resulting from an external force upon the head. So that force has to be plausible. So, if you drop a feather on your forehead, that shouldn't cause a traumatic brain injury. But it can really be any object. It also, though, includes penetrating injuries. So the one on the right-hand side, this is a person having a rather bad day. In fact, this is an unsurvivable injury. It's caused by a military a high-velocity round. We effectively almost never see an injury crossing the midline survival. Though, having said never, we did have 2 cases from the whole of the last 20 years Afghanistan campaign. So the rule is, big injuries like that, they're never going to see you or I. But as well as kind of the impact trauma TBI that we're probably most familiar with, you do also get TBI in other contexts. And militarily, I spend quite a lot of time thinking about blast and explosions, but we also see it in other things. So heat injury, although it's not traumatic per se, it seems to cause a very similar injury. But then other things like vibration. So we do see it in vehicles. And again, there are kind of civilian collieries where you might see these injuries. But by and large, the most common thing would be an external kind of blunt trauma, so an impact trauma. There's lots of ways of classifying it. I'll talk very briefly on that in a bit. When we boil it down in the West, most of the causes we see are related to kind of road traffic collisions and falls, and also sports. The old kind of common word is concussion, and this is effectively synonymous. In many respects, it's probably a better word to use of patients. One of my skits when I'm explaining these injuries to soldiers is that the words are unhelpful, and calling an injury mild when you're seeing someone 6 months, 12 months down the line who's off work still and is quite disabled by it doesn't really feel right. And conversely, telling people they've had a traumatic injury gives them connotations that there's something catastrophic happened in their brain that's never going to recover. Whereas the reality is the majority of these injuries are going to recover probably with or without us. But hopefully I'd like to think we speed things up for them. Ultimately, we do know, however, that there are people who have significant morbidity out for a long time after it, and certainly there are things we can do about that. And I'll come on to how we approach it in the MOD, and certainly we've got colleagues in concussion services around the country who take similar elements of that approach. The problem, it's big. There's 50 million odd a year worldwide. That's almost certainly an underestimate. The incidence is high, so it's not an uncommon condition. It's very much a common condition. Moderate severe TBI is a very major cause of morbidity in the young, but there's also another peak of injury, kind of for grey trauma, in the over 60 group. By and large, they're at least 80%, and in all reality, a lot more percentage, probably more 90–95% are kind of on the mild spectrum of things. And certainly this is something which has over the last 20 years really become more in the fore of people's consciousness. So certainly in the military, it's considered to be kind of a silent epidemic, and then it's gone on from being a silent epidemic to being said to be the signature injury of the conflicts us and allies have been involved in the last kind of 15–20 years. It costs a lot of money. Estimates, 200 billion per year, US dollars. The US also spends a lot of money on research. They spent $6 billion in the last 20 years. So we know a bit more about it. Congress, who spent the $6 billion, however, is a little upset there's no treatment for it, or no specific treatment yet. But we'll come on to that in a bit. Because it's me talking and it's the UK military, we do have our own figures. We have quite so people who go out on operations, about 1 in 20 get an MTBI in that period of time. If they're in a kind of a more physical combat role, that can be up to 10%, 1 in 10. In the US, the figures are even higher. This probably doesn't reflect that Americans hit their heads more. It probably reflects differences in presentation and so on and so forth. Ultimately, it's a big problem. So how about what do we actually do about it? So I'm going to kind of talk through how we approach this clinically. So the first thing is, people, I'll come on to the very acute thing if you're seeing this person, straight afterwards, PIP-side or in primary care. But the general clinical approach to somebody in the room is to start to understand the background and to give context. And certainly in my line of work, but also more widely, there will be occupational considerations. So some of the so whats of how you manage the injury would be different, whether this person moves boxes in stores, if he's a heavy goods vehicle lorry driver, or indeed now and again I come across fast jet pilots making the wrong decision about somebody returning to work, and they crash $100 million worth of aircraft, is considered to be a bad thing. So you want to know about job, social situation, driving hobbies, etc. Past medical history is relevant, and prior head injuries. So a lot of people who have head injuries have had prior ones, especially when you're talking about the young physical population I have, or sporting populations. Rugby's all over the news at the moment. On average, in pro rugby, they're seeing a concussion per player every 9 matches. So understanding the kind of the context of this individual and the other injuries they're having is a key. So what about the detail, when it happened? The mechanism is helpful to know, what was the force, but also mitigation, was the person wearing a helmet when they came off the bike? All these sorts of things can just help with formulation down the line. And again, sometimes there's a bit more of an unusual thing going on. So, was this a blast injury, or was there something else happening in a more common context? And then we kind of look at the immediate so what, so were they amnestic and were there other immediate sequelae? Hopefully this video works. So this is the sort of thing which has happened immediately. This guy's been skateboarding, and I'm sure people can notice that something not quite right is going on there. And in fact, this guy is gone straight into a seizure. So this is a very common sort of thing to happen immediately after. It's very dramatic. But equally, often people won't know, because people understand that something has gone wrong. There's no kind of neurologist or doctor sat there to phenotype what's happened or describe the seizure semiology. And I thought we might want to. Okay, and here's another example. This is one of my favorite ones from the NFL, and partly because they get so many head injuries and they're filmed. But this guy now is kind of showing an Archer sign, and he's kind of gone into initial. So this is initially somewhat decelerative posturing. And these again are quite common. Up to about 2/3 can have some form of this immediate kind of seizure-like activity, but it passes quite quickly. So this is another one, another sport which causes lots of head injuries, and a fairly hard knock, quite typical in this sort of sport. But this guy's got up really fast, but he's not right. So again, in any sorts of things, this is what sports doctors are particularly looking out for, and you know, is this a kind of a trivial injury? Is this just something that someone can rapidly recover from, or is this person going to need to be excluded? I think if you're in the area doing that, you'll kind of know a bit more about it, but certainly these are the sorts of considerations we need to look at in clinic. I'm not going to talk a lot about the underlying science of it, but there are immediate tissue changes in the brain which are in response to the trauma that result in these kind of immediate sequelae, and things like the loss of consciousness will come onto, and memory disruption, and then these are also setting the scene for what's going to happen and the say what's of it. There's certainly some interest in how this relates to energy processing in the brain and cells, and this then kind of comes on to some of the techniques which people are starting to look at for early treatments or even prophylaxis. Ultimately, we know a lot of this is happening. There's a very key interlink though between both the activity and then the blood flow. So this derives from the concept of cerebrovascular coupling, which is where your kind of activity in your neurons is very closely coupled to regional kind of local cerebral blood flow, and this becomes disordered, and actually it can stay disordered for some time. So even in a kind of subconcussive injury, so someone's not symptomatic with, that can be disordered for 3 months in some studies, which also then kind of feeds into our so what's, you know, what are we thinking about this person over time? You know, should this person go back and box next week, for instance? Ultimately, though, all of this stuff we know kind of happens. It's complex, and it doesn't necessarily feed in at this moment in time to how we approach things clinically, which is probably nice for us to know on the clinical side of things. So early management then. Ultimately, we've got to work out if this person needs immediate care. So is this somebody I need to be sending to A&E? And if not, we've kind of got to work out, you know, what are we going to do with this injury? And then ideally take some action to help start treating and mitigate it. I put this up. I use a similar one, but it's not published yet in our own thing. Ultimately, we're very closely aligned with our US military colleagues, and this is a very well thought out and pragmatic approach. In terms of that very early thing, it really comes down to kind of excluding your red flags, and that's in that sidebar 1 box. I won't read them out. I think they all kind of stand to reason over the sorts of things we'd expect. You know, you're seeing somebody an hour later and they're not conscious. That's a problem. I don't think many of us would need a box in order to think that would need flagging up. And ultimately, that's going to, you know, go to A&E, and generally, if they've got these sorts of things, they'll end up with a scan, and it's then the scan which will tell you if there's a structural problem or not, and really dictate that early management. So are they visiting our neurosurgical friends, or are they being observed for a bit and then coming back out again? So once we've kind of thought about that early bit and whether we need to do something immediately and send them in, we then have to kind of think about what sort of an injury they've had. And this is where it comes into classification criteria. There's lots of different criteria. It's contentious as to which one you should pick. But ultimately there's a lot of similarities between them. I think overall classifying injuries is probably quite important for prognosticating and stratifying them. So I'm going to do something rather different with a severe brain injury to somebody who's minimally symptomatic with a mild injury. Again, sometimes this is rather obvious, and probably it matters a bit more about when we're looking at and organising our data sets about how we classify, as opposed to necessarily really having driven what's happened in front of us. So I said there are lots of criteria. I'm not going to bore everyone by reading all of these out. On the top line there, you can see the features which people are deriving into. So ultimately, although there's all of these criteria, they're really drilling down into the same groups of features. As you can see, I really do like the VA DoD, and these are the criteria that we've adopted in the UK military as well. And ultimately, we split injuries up into mild, moderate, severe. The main criteria based on imaging, so you don't always have to have imaging. Now and again, though, I do find people in clinic who haven't been imaged, but actually do have changes. You don't tend to miss severe ones, although there are certainly I'm aware of cases where that has been done, but that's usually because there's in the setting of like polytrauma, and there's so many complicating injuries that nobody's really thought about the head. But otherwise, it really comes down to get down to a few points. It's the consciousness, the altered behaviour, the amnestic period, and Glasgow Coma Scale. However, having said all of those, I don't really find them all useful. These are the useful ones. So the imaging helps. That tells you if there's a structural problem there. The caveat with imaging is it's got to be normal imaging. So no fancy 7 Tesla scans with diffusion tensor imaging, or bold spin MRI. These are normal scanners in a standard DGH hospital or a CT scanner. And mild injuries would be normal on that. Loss of consciousness period is helpful, but you've got to be quite careful in terms of how you tease that out of people in the history. Really, I mean, bystanders are rather shocked if somebody's completely unresponsive for 30 minutes. So at that point, those sorts of injuries, you'll tend to have a different story. A person's been paramedics taken into hospital. Severe injuries, actually, the period is usually quite hard. Well, you can't work it out because it turns out that there's been sedation and ventilation given at some point, and therefore that you don't know what that period would have been. Alteration is helpful, but often it's not something that is that obvious. The amnestic period is really helpful. So this is something you can actually tease out of people in a clinic room. They can talk to you about when, so often they'll have some flashes of memory early on. So they'll say, oh, well, remember the ambulance. I don't remember the drive to the hospital. I don't really remember going in there. Something happened to me then. But then later on, say 6 hours later, they kind of actually, by the time that time, things have settled down. They then remember the journey back. They remember their friend kind of, stopping and getting them some food, or often it'll then be overnight. So they've got scanty memory from the day, but by the following morning, memories then settle down and we're out of their amnestic period. So those ones are helpful. GCS, in all honesty, I found is next to useless because patients don't know it. It's been poorly recorded. You don't know who's really actually recording it and whether they knew what they're doing. So although those criteria look quite complicated, it really comes down to imaging, how long they're unconscious for, and the amnestic period. And particularly out of those, the imaging and the period of amnesia. And mild injuries up to about a day is, and probably most of the time in clinic, I'll see people with a reasonable injury be in the 6 to 12 hour sort of mark. But a lot of people with much shorter periods or no post-traumatic amnesia. So symptoms, and we can kind of break these up into a few different groups as kind of physical symptoms, cognitive symptoms, and then mental health. The most common things we see are I'm sorry, I better just turn that back on 1 sec. My apologies. So again, I'm not going to read all through these, but there's certainly the key groups of symptoms to think about. These are all put into order of frequency, and clearly, headache right at the top of the list there. And we'll talk a bit about that later on. But we'll certainly say a lot of other things. There's lots of fatigue, dizziness, vestibular dysfunction, and sleep dysfunction. And then the headachy people here, because I know that's what we're all interested in, will notice a lot of those things down the bottom are actually quite migrainous features: nausea, sensitivity to light and sound. So again, headache is really key and important, and we'll talk about that. There are things available to help kind of remind you, rhythm meters, one of the common ones, and these can be used in clinic. So how do we actually go about treating these injuries then? There isn't a specific brain injury treatment, which kind of lets us off the hook a little bit. A lot of the time, actually, it's recognizing that we don't need to treat. So often it can be quite simple measures when we see people early on. And Track TBI is a large US consortium that's followed people who presented to A&E. And we found in Track that about half of people after a mild brain injury recover in 2 weeks. If you haven't recovered at 2 weeks, you've got about 50% chance of still being symptomatic at 3 months. But that tells you that, you know, around about half the majority are going to be better within 2 weeks. So there isn't a lot of intervention required other than just kind of simple things and making sure things don't go wrong. But equally, it's also about signposting and giving people a mechanism to come and, you know, seek the help they need thereafter. There is evidence about early management improving outcome, and certainly we can see that in our own UK data. And again, there's evidence for, you know, more specialist services. And what that really, like anything in medicine, represents is, you know, where there's familiarity with the patients and the kind of the outcomes of the presentation, then tailored treatment approaches tend to work. So again, a lot of this is quite simple stuff, and it's about supporting people, so allowing them to rest, but also allowing them to gradually return to activity and avoiding bad things. So, you know, too much drinking early on, you know, poor sleep, and sedatives, and also just returning to full work or full activity soon can actually cause issues. So it's kind of like educating patients and giving them a balanced approach. So the clinical pathway we manage people acutely early, and we reach out into primary care and ask people to follow our kind of our SOPs we give, which kind of sets out management over the first couple of weeks. And then after 2 weeks, we ask people who are still symptomatic to be referred into our central service, and we kind of have a program talking about symptomatic approaches and management in primary care with kind of analgesia for headaches and physiotherapy approaches. And then people come through an outpatient program where we'll see and assess. This is within the first 3 months, but certainly we're trying to bring that time down. And then where people remain symptomatic, we use a residential course where we bring people in for 3 weeks to kind of really drill into symptoms and educational approaches. And we have a longer term bit where people can get back in touch with us if they need. Now, clearly, you know, half of people are getting better before they even come to our attention, at least. So this sort of thing is kind of, this is a back end approach as opposed to necessarily what needs to be used front top. And then it's really symptoms based. So kind of all these symptoms have things which can be done, whether it's education or specific intervention. And then a lot of things overlap. So some of our headache approaches, for instance, can also pharmacologically overlap with approaches to sleep, etc. But ultimately, a lot of this is about recognizing, normalizing, and supporting recovery. The only thing I want to bring out here is that we work as a interdisciplinary team. So the setup in my service is I work with a psychologist, occupational therapist, and some physiotherapists in order to really break up these symptoms and support people back into work. And we do have some data which shows that we probably have improved outcomes through doing that. So just by adding vestibular treatment alone, we've improved our early return to work outcome by about 25% by addressing the vestibular dysfunction. So post-traumatic headache, then, it's frequent and can often be persistent. Definition-wise is by the ICHD criteria is within 7 days, but I see plenty of people who clearly have post-traumatic headache and have started without that. We do need to remember ICHD is effectively a research criteria, so it will draw hard lines for research reasons which don't necessarily match up clinically, and of course they are a set of criteria which are under review. There are other things to consider if we're not talking about a mild injury, you know, craniotomy associated headaches, etc. They are more common in mild traumatic injuries than moderate and severe, although one kind of caveat to that is be aware of kind of agnosia in the early phases in more severe injuries. So people kind of the pathways haven't knitted together enough for them to realise they have symptoms, and you do then get these late symptoms emerging, whether they're vestibular or headache or otherwise. Effectively, the criteria really boil down to this. Georgie Lambry from a few years ago, I borrowed his lovely table, and the criteria in many respects aren't actually that helpful. Either it's an acute headache or a persistent headache, and you can't tell that until they've had it for 3 months, and then they associate it with mild injuries or moderate severe injuries, which we kind of already know because we've typed it. So really what we're saying is that there's a headache and it's happened after trauma. So that bit of it is not very helpful. So what's our actual approach to it then? It really boils down to phenotype. And I'll kind of break the news to you now. It's mostly migraine, but there is a but sometimes. So they're common. It does actually often occur later than 7 days. And I think one of the things sometimes we see, particularly on the medical legal side, worrying about malingering, it's not actually that common in headache, which might be a little bit different maybe to whiplash, depending on the literature you read. And unlike whiplash, for instance, litigation doesn't seem to affect the outcomes in post-traumatic headache. Military then, again, I'm wearing green, so I have to talk about this. We get quite high rates of migraine prevalence. So the general population is knocking around kind of 6% men, 20% women. There are higher rates in the military for some reason. That might be partly because the general population estimates are low, but also I think we expose our populations to lots of triggers, and sleep, stress, heat exertion, all these sorts of things lead into it. And then that links in because we've already have slightly high rates of migraine. Interesting enough, our rates of migraine increase when we deploy people, and then in the US, up to 20% of these people are then suffering a concussion. So ultimately, that all kind of conspires to produce a lot of very migrainous post-traumatic headache. And this is just that's come out terribly. So we have up to kind of half people in deployment. I think it's really a bit less than that, probably about 30% of soldiers in deployment have instant migraine during their deployment. And then you add an MTBI on top of it, and basically all of them have a migrainous post-traumatic headache in this particular series. There are some other things, and there is a bit of tension type headache in there. I'm not going to go into the what's and wherefores of that. Certainly there is a school of thought that most tension type headache is mild migraine. Now I sit in the clinic where I'm seeing kind of a selected group of people. I don't make many diagnoses of tension type headache. I make a lot of migraine diagnosis and not a probable migraine diagnosis. There are instances of trigeminal autonomic cathalgias mixed into this as well. This is highly variable by the series you look at. It seems if you're Danish, it might be as much as 20%. I think that's probably a gross overestimate. In my own series, I've diagnosed 2 in the last year. So they do exist. Nowhere near as high as 20%, I'd posit overall. But certainly, it should be something on one's mind when they're phenotyping. So it's mostly migraine, but sometimes it might not be. And this is the same data. So natural history then, very common early on. And, depending on the study you look at, even higher than 80%. So as much as 95% of people early on will get post-traumatic headache. But then it persists, and actually the headache is probably one of the more persistent of all the symptoms. So there are groups of people there who persist out for years, and some, and the longest follow-up study I've come across was 22 years, and they still had between 6 and 18% at that point. So the headache is important, and certainly in some people it's a major issue. In terms of the treatment then, I'm conscious of the time. Ultimately, it's treating the phenotype, and I think a lot, most of us here should be pretty familiar with migraine management, and that's really what it boils down to. And then there are a few other things we can do, and certainly in the future we're going to be probably doing a lot more treatments like the CGRP monoclonals, and I'll talk a little bit about that. Probably my only plea is, alongside its migraine, is don't give opiates. So there is evidence, particularly in post-traumatic headache in the US forces, where it's one of the few factors which increases the rate of people leaving service is being treated with opiates for their headache afterwards. So we know opiates are not good for migraine, and that carries forward to post-traumatic headache. This is from Ashina et al. A couple of years ago. Effectively, we've got to think about the phenotype. On my side, I tend to go down the right-hand side. And then really, we've got acute treatment, and then at some point we bring in preventatives. We're not really sure when to do that. So I'll tell you kind of what I do. Reminder, avoid opiates. And then NSAIDs early on are helpful. Probably doesn't matter which one, there isn't evidence to pick between them. I tend to pick naproxen early, just because it's relatively well tolerated and fairly potent. I tend to add prochlorperazine to it. There's independent evidence of prochlorperazine in migraine being having analgesic property. In fact, it's superior IV to hydrocodone in a US A&E study in migraine. So, but it's also very helpful for the vestibular bits early on, but caveated by only in the first few days. And this is then a period where we're talking about relative rest for the first few days and then gradual return to activity. So early on, treat the headache, but treat fairly aggressively, but still trying to move people back into activity. Exertional headache is very common. We see, it's a common part of migraine, and it frequently lingers in those who are otherwise resolving. It's a major limiter of activity and normalization, and certainly where we just, that phase where people are calming down and the exertional headache is then what's the limiting factor. I'll often use prophylactic analgesia just so that they can get back into activity, and it helps that normalization process. The caveat being, I don't give analgesia to allow somebody to go and box or play rugby, because that would just be madness. Treatment, a bit contentious. I think, with the track data, we know that if after a couple of weeks you've got a high likelihood or about 50% chance of having a persistent headache syndrome. So particularly where headache is intrusive and limiting, I think actually we can justify starting a prophylactic treatment quite early. And certainly I'll do that, seeing people in clinic at as early as 2 weeks, 4 weeks certainly. Preventative treatment, we don't know exactly what to use. There isn't the data to guide that at the moment. And it's really down migraine guidelines. So tricyclics, I find amitriptyline and its relatives, nortriptyline, defirpin, are useful. There's a reasonable response in migraine. Again, like anything, if you can find a double reason to use it, I think that's quite compelling. Sleep dysregulation is very common, and in the right person, I think that's helpful. However, the side effects can be limiting, so it's to be borne in mind. Propranolol, good, particularly it seems for me clinically with exertional headache, but certainly in my soldiers it limits their CV fitness, so a proportion will just not want it because the not being able to perform in the gym is even worse than the headache. Candesartan ARB, that's also helpful, and actually pretty well tolerated in this population. Topiramate works for migraine. Don't give it to people after a brain injury. You get one standard deviation decrement in processing speed, and a few other cognitive metrics. So I find that people who are already cognitively struggling, adding topiramate into the mix actually just makes things worse. So even if the headache's better, they're not thanking you for it. So it can be used, but I think you'd have to have a good reason to do so. GONS, the data is poor, but actually they're quite useful in the right cases. I tend to use them for people who are really struggling when introducing another treatment, and I often use them as a bridge to get people fit enough to come into a rehab program. So I'll give them kind of a week or at the beginning of a 3-week program just to really calm things down, to allow them to get on with their rehab and start progressing and normalizing. CGRP, it's a bit early data-wise. There's a good reduction in monthly, well, a reasonable reduction in monthly headache days with erenumab in a Danish study. I think the thing to bear in mind about that study was it had some pretty persistent people in it already. So I think they were picking the hardest route to treat and not necessarily the most potent CGRP, just the first one out with blocks. So the data is probably a little bit poorer than one might hope. Certainly anecdotally, in our series where we've got quite a few soldiers now on fremunezumab, we're seeing really quite good results. And as people know, with the CGRP monoclonals, they're incredibly well tolerated. So there are currently 2 trials running, and these are now looking at people very early, so starting people within 7 days when they've got a headache. You could argue that's probably a bit too early, but I think early within the first few weeks is going to be a direction of travel. And of course, we've got some more CGRPs coming through. So epitemesimab as the IV infusion is going to potentially be of real interest there. Unfortunately, as far as I can figure out, the company don't have any plans to look at PTH yet, but I'm sure others may. So in summary, MTBI is common, and it's frequently disabling, and post-traumatic headache is a major part of that. It's the commonest symptom. It's probably one of the most debilitating of all of them, and I think we know that chronic pain is a problem, and when pain's there, it kind of dominates the picture. Early management is beneficial. And there are a lot of management approaches we can take. Most recover really well. In clinic, I tell people that basically I expect everyone to get normal or near normal in time. And certainly if we aggressively treat their headaches and their vestibular dysfunction and kind of pay attention to the cognition and educational aspects, that's key. One glaring problem though is people with mental health problems in comorbidity are probably have the worst outcomes, and that's very difficult to manage. And again, that certainly speaks to needing an MDT approach, and that's kind of one of the benefits of having a psychologist with me. So really, it's identify the symptoms and treat them, and overall, you can generally be pretty reassuring in these cases. I'll stop there. I'm conscious of the time, but thank you very much. I'm happy to either take questions now or later.
James, can you hear me?
Oh, now I can, yes.
Yes, right. Can you just unshare your screen for a second? Great. Okay, so thank you, James. That was an excellent summary of mild traumatic head injury. While the questions are coming in, and I encourage the listeners and viewers to type in questions in the chat bar at the bottom. Just a couple of questions. The one thing that I've noticed from my own practice is if you compare two, these are very general observations, but if you compare 2 groups of people, say for example, rugby players that have sustained a concussion injury during a game, and someone who's been assaulted or beaten around the head, I find that when you begin to attach emotionality to the nature of the injury, that can have a significant impact on how long the symptoms last for. And relatively, the people that have sort of attached this negativity towards, and understandably being beaten down the head or assaulted, they tend to have a worse outcome than those where the type of injury was done playing sport or doing something else. Would you agree with that?
I would, up to a point. I think there are certainly there are factors in some people which kind of end up making that the case, and equally some people are resilient to it. So bear in mind, I see a skewed population by definition. Everyone I see on the military side is kind of joined, and they expect to be in a military organization. A lot of people I see are, say, infantry. They've joined to fight. And probably about a third of the people I see have been assaulted. Now, the difference is soldiers kind of expect that. So they probably went out on Friday, Saturday night, and half kind of fancied maybe getting into a tussle. It's just this time they came off worse. So I think that's rather different to somebody who really, is a bystander and just ends up being assaulted or, randomly attacked. And I think it really, and that's kind of what I was touching on by saying that the mental health aspect is very important. So I think if you don't have mental health involved, I would generally reassure people that I expect full recovery at some point. The mental health aspect is the bit which can kind of kibosh that. And certainly it's particularly so when there's that kind of external locus. And it's one of the things that we tend to address. So within my own team, I'll have that address with our psychologist, and ultimately we also do tap into our mental health services. PTSD, actually, I'm seeing a less of it at the moment, and that probably reflects the fact that the military has not been actively war fighting. And, you know, the average person in our service stays in for about 4 years in the infantry before leaving. So all those people who are fighting in Iraq and Afghanistan they're either old like me, and presumably because we're still around, you know, we didn't get it, or actually the bulk of that force is now left and they're veterans. So PTSD is a major problem. I don't want to get into a lot of complexity there, but there are definitely factors which make, you know, so sometimes you get false attribution. So what is really PTSD gets labeled as MTBI and vice versa. So that's something which, you know, has to be borne in mind. And certainly if you're seeing someone, you know, 2 years down the line and they're very disabled by it, I'd argue that the trauma, you know, actual physical force component of it is probably not the big driver here anymore. So certainly, you know, you need to recognize it for people, and certainly if there are ongoing symptoms. But again, this is kind of where you might then be thinking, have I missed a more severe injury, and actually be scanning people and looking for that kind of signature contusion or something underneath, which is there. But usually it turns out that this is a strong mental health presentation, and then they you know, you're now into kind of the mental health territory, which I'd be happy to talk about, but I think we're getting a little off topic.
Yeah. Okay, I'm just scanning through the questions. There's some really good questions here. So, first of all, is there any data in mild traumatic brain injury in what proportion of patients go on to get CSF leaks? Again, this is a problem in patients who attend complex headache clinics.
Yeah, so in your big bulk, bearing in mind how common these are and actually how relatively uncommon CSF leak is, I don't think it's a major thing, but certainly, you know, you do see people who kind of attribute a minor trauma to then getting the CSF leak. But I think the other problem is actually, you know, minor knocks and things happening are a common part of life. So somebody who's had a CSF leak may well find something to latch onto. But no, it's not really at the forefront of my mind. And certainly, you know, in the last 500 people I've seen in the MTBI service here, no one's had a CSF leak. But certainly, you know, I do look for them because I'd love to find one. But I hope that answers the question. So it's uncommon.
So in patients that have had mild traumatic brain injuries, are there increased risk of developing seizures later on compared to someone who hasn't had a head injury?
So this is where we need to be careful. Mild traumatic brain injury, yes, but only a very small amount. So we're talking like a 0.2% per annum increase. And that's quite important because, you know, as well as looking after storemen, I see people who like to fly very big, expensive, fast things for a living. And we can't tolerate a lot of seizure risk because, strange enough, UK PLC gets upset if 100 million quid's worth of plane ends up at the bottom of the Mediterranean. So I don't want it to be my fault, as opposed to, you might remember news from a little while ago, somebody forgot to take an engine cover off. So MTBI, no. Moderate severe TBI, yes. And this is why DVLA will ban people from driving for a variable length of time. And just, you know, to close that bit off, in a pilot with a severe TBI would be banned on the basis of seizure alone if he's not had a seizure for at least 10 years from flying again. So it's a major consideration. But in MTBI, it's such a small, modest rise. It does happen, but it isn't a major consideration.
Okay. How often do we see extrapyramidal side effects with prochlorperazine? I mean, I can probably answer that. I think I generally tend to avoid prochlorperazine in younger women because they do get funny histonic reactions. But because you're dealing with a different population, I suspect you don't see it as often, do, James?
No, and also I'm not you know, this isn't your little old lady who somebody's left them on it for 5 years. You know, you're using it for a short period of time. The other bit is you know, bearing in mind, as well as the headache management, we're also managing vestibular dysfunction. So prochlorperazine is useful early with those symptoms, but actually it's going to be detrimental as you're trying to get people moving and normalizing again. So it's kind of that idea of kind of you're paralyzing your labyrinth, and that's just not going to allow them to progress. So I use it kind of in a short burst early just to get things calm, and then or on a PRM basis, but not on a regular basis.
Is there a gender difference in terms of recovery rate or pattern?
Yes, there is. So there's quite a lot of interesting gender differences. On the one hand, severe injuries, women do better than men. And that's led to clinical trials of progesterone in severe TBI. Disappointingly, they were negative, but that's probably because of a trial design. I could spend a whole hour talking about why all the trials have failed over the last 30 years because of poor trial design. Otherwise, women are actually more susceptible to mild traumatic brain injuries, particularly in a sporting context. And there's a lot of work going into why that might be. It probably boils down to being smaller and having lower muscle bulk. Whereas two blokes having in a rugby tackle, they tackle each other, land on the ground. The great big stocky neck stops for second contact with the head on the ground. In the women's game, what we often see is a second contact between head and ground after the tackle. And there's actually evidence that a physiotherapy approach to increasing neck strength reduces the occurrence of sport concussion, sport MTBI. So there absolutely are differences, and it's everything from quite maybe relatively obvious physical things all the way to some probably clever biochemical underlying bits. And it's certainly an area of study. It's one of the things we're studying in our own PREDICT consortium.
Great. And final question. We talked about CGRP. What is your experience with Botox and treating patients with persistent headache after?
Great when you need it. I've only had to do it a few times though. So that was a particularly resistant person. I mean, a lot of my own personal experience has fortunately come after the advent of CGRP. So all of my people have been put onto CGRP really in the last few years. And very rarely have we then had to go and add anything else in. But when we've had to add it in, Botox has been helpful. I suspect we might hear a little bit about that in the neck context as well, because of course there is that other consideration along with these kind of PTH MTBI headache issues.
Great. Well, I'd like to thank James again for his excellent talk. We've covered a lot of ground today, and we know a lot more about this important topic. Now I'm going to introduce the next two speakers. The next part of this evening's talk is about cervicogenic headache. The neck is obviously probably the most important bit of this, which connects obviously our head to the rest of us. And neck problems commonly cause headaches, and we're going to learn this evening about how to assess patients with headaches related to neck problems. So I now hand you over to first of all, Sonia Thompson, who is a physiotherapist based up in Belfast, and then to Elizabeth Hussey, who's a senior osteopath who's been working with headache patients for many years and is very involved with educational programs around headaches. So Sonia, over to you. Thank you very much.
Sorry, Dan, bear with me there. Wait a sec. Yeah, so that's us. Liz and I are going to spend the next few minutes chatting a wee bit about cervicogenic headache, and thanks, Ben, for your warm welcome. So the things we hope to cover this evening are looking at the pathophysiology of cervicogenic headache, some of the diagnostic features, and diagnostic criteria for cervicogenic headache, how we would go about assessing someone with potential cervicogenic headache or how to exclude it, and then looking at some of the management options. And then we'll move on and talk about some cervical drivers and other primary headache conditions. So what is cervicogenic headache? Well, essentially it's headache caused by a dysfunction in the neck. So quite literally a pain in the neck. It's not uncommon. So depending on the literature that you look at, it might affect anything between 1% and 4% of the population. Although in chronic headache sufferers, the incidence increases. So you might see between 15 and 20% of people with chronic headache suffering from cervicogenic headache. And if we try and have a little bit of a look there at the pathophysiology of cervicogenic headache, just to see exactly what's going on, essentially, it's because of the convergence of the sensory input from the upper cervical spine into the trigeminal spinal nucleus. So you've got lots of structures there that might potentially be contributing to cervicogenic headache. That includes your upper cervical facets, upper cervical muscles, your C2, C3 disc, vertebral and internal carotid arteries, dura of the upper spinal cord, and posterior cranial fossa. So if we have a bit of a look at some of the patterns of pain that come with cervicogenic headache, this builds on some of the work originally done by Bogduck and as well as Peter Goldsby, who looked at providing noxious stimuli to C1, C2, C3 and determined where people would describe the pain. So when that was provided to the posterior area, they were feeling pain in the frontal region, and the same was true vice versa. So a noxious stimuli provided to the frontal region was causing pain in the occipital area, which is important because then that kind of highlights the bidirectional nature of the pain. But when we look at some of the muscular trigger points on the right-hand side there, you can also see other patterns of pain referral, and certainly that's something we would see commonly in the patients that present with this condition. So when we look at the diagnostic criteria according to the ICD, it's HD3, essentially it comes from a combination of criteria. So initially the work done by Sastad in the 80s, where they looked at trying to identify it as a distinct headache disorder. They looked at neck examinations, and then the more recent criteria has looked at including the diagnostic blockades to confirm the diagnosis. So the current criteria includes both of those. So if we look at that in a bit more detail, essentially then you're looking at any headache that fulfills criteria B there, so clinical or imaging evidence of a disorder in the neck or cervical spine that is known to cause headaches. So that takes us back to the previous slide where we think about those facets, muscles, discs, dura, arteries, those kinds of things. But then if we look at criteria C, then it says that it should have at least two of the following. So headache that's developed in relation to an onset of a neck disorder, and then that it would improve or to resolve with an improvement in the neck disorder. That the third one then is that your cervical range of movement would be reduced and that your headache is made worse by moving your cervical spine. And then lastly, then including the diagnostic blockade. So you would expect to see a resolution of the headache with those diagnostic blockades. But sometimes that can be useful in clinical practice if we have access to those, but that's not always the case. However, as we pointed out with the last presentation there, sometimes the criteria is set for research alone and it has some kind of clinical difficulties. So if we think about looking at the criterion B, it looks like the diagnosis can be made on a single criteria, which isn't the case. It also negates the particular characteristics of the headache, and we know that with cervicogenic headache in particular, that there are very distinct characteristics that the patient will describe. And also, while it talks about a reduced range of movement, it doesn't really go into that in any great detail. So, for example, lots of the patients that we see who maybe have degenerative changes in the neck will show reduced range of movement, but not necessarily have cervicogenic headache. And normal age-related changes will reduce, side flexion very commonly in the neck. And again, they won't have cervicogenic headache. So this new criteria proposed here in 2018 looks at kind of trying to tie it down in a bit more detail. So it looks at the pain being unilateral, which is a good thing, and we'll go on to talk about that in a wee second. And that the it kind of quantifies the degree of improvement or resolution that you would expect with a change in the improvement in the neck disorder. And then it ties down the range of movement a bit more tightly, where it's looking at reduction in cervical rotation, which more commonly happens in the upper cervical spine by more than 10 degrees on the affected side. So it's starting to narrow it down rather than a big broad look at the neck. It also starts to integrate manual examination of the neck. So by palpation of the neck, and whether or not that would introduce or amplify the headache. So we might see in the future that some of the criteria starts to include these, and I think that would be a kind of a good step forward. So in terms of the clinical features of cervicogenic headache, what do these patients describe? So it is often unilateral, but not exclusively so. So if someone is complaining of unilateral pain in the neck that's really in one side of the head, I would be thinking, is there a cervicogenic element here? And also it tends to stay on that side. So you might be familiar with patients with migraine who might during one attack have it on the left-hand side and with another attack have it on the right. That's not really the case with people with cervicogenic headache. It tends to stay more on, well, it tends to be side locked. For those patients who describe bilateral pain, I would inquire a bit further and see, is it predominantly on one side? It's predominantly on the right, feel a wee bit in the left, but it's mostly on the right. And then it still might be cervicogenic headache, but more commonly unilateral pain. Because these people are often seeking intervention for their headache, it tends to be it tends to be moderate to severe pain, unlike the tension type headache. So can be intermittent or constant, but it's usually interfering enough for them to seek intervention for it. And the way they describe the pain is different. So often they'll say it's deep or it feels heavy. It starts in the back and comes forward. I suppose that comes down to how well patients are at describing pain, but those are kind of typical things that they'll say. And they don't usually describe it as throbbing, which tends to sit with migraine, but again, it comes down to how good our patients are at describing pain, and we all know that some are better than others. And then, as we talked about before there, in terms of the restriction in the range of movement, it tends to be a restriction in flexion or restriction rotation or a combination of both of those. I'm less bothered, as I say, when it's kind of side flexion. And then we also kind of can take clues from what the patient's telling us in terms of the things that make their headache symptoms worse. So if they're saying it's worse with physical activity, so for example, gardening, it's worse after sitting for a long day on the computer. It's worse when I lie down in bed, I can't get comfortable. Those kinds of things might raise the suspicion of cervicogenic headache. And it tends to kind of be more amenable to influence, so I can do things or change position that tend to make it better or worse. And then when we think about headache as well, we also think about the signs and symptoms. So it's not always just the headache that they describe of. So they may have dizziness, commonly, they may have nausea, photophobia or phonophobia. But what I would say with those is that they are much less dominant. So they might have one, but usually not all. And I suppose in my experience, the dizziness would be the most common. But unlike a migraine sufferer who might complain of lots of those things and tick all the boxes. So I've touched a little bit on this already, and I picked migraine because I think that's a big proponent of what we see in headache centres or with people coming in seeking attention for headache. So these are kind of the key differences. So usually there's an onset of neck pain and headache at the same time, which isn't always the case with migraine. And those ags and eases, so things that they do with their head and their neck or their movement, can make their symptoms, so their headache, worse. Often it's going from back to front, not always, but more commonly in that direction. As I mentioned before, it tends to stay more on one side. And those signs and symptoms, so it's usually the pain, restriction of the range of movement. They might feel a bit sick if it's really severe, but they're not complaining of lots and lots of signs and symptoms, and it might be one as opposed to the collection of them all. And another key feature is that they don't often respond to the typical migraine therapies. And I know in the last talk we talked a bit about the benefits of CGRP in relation to managing headache, but in cervicogenic headache, there's no CGRP released involved in the pathophysiology, so it's unlikely to respond to those therapies. Now, unless we're doing research, we're probably not able to bring out these tools and check and see if that's going on with the patient sitting in front of us, but it's just worth bearing in mind. So then if we think about how we would assess these patients and how do we pick out if it is cervicogenic headache, and then most importantly, what we're going to do about it. As with all headache disorders, we need to take a really good subjective history, and it's no truer with cervicogenic headache than it is with other headache disorders. But in your subjective history, you're obviously trying to eliminate red flags and identify any need for onward referral or further investigation. You're establishing when it comes on, how long it lasts for, what their neck is like, what they're like at baseline, what they're like when they're worse, and then looking at what makes it better or worse. Okay, so they're the kind of key things to pick out. And I suppose in terms of addressing what you're going to do to help this patient out, you want to see how they're functioning. So are they still at work? Are they sleeping? Are they still able to take on all the responsibilities? Are there just particular activities that they can't do because they can't move effectively? And I suppose key in the subjective history taken as well is what they expect to get from coming to see you. And sometimes that's about how it's been portrayed. So they might have this impression that they're coming in to have their neck hauled and pulled and be terrified, and they're sitting there in front of you shaking in the chair. Or they might think physio for headache or an osteopath. Sure, it's not that at all, you know. So I think it's really important to pick those things out at the first session, and then that'll help kind of navigate the road as we go down it. Now we saw when we looked at the criteria there that you can have clinical imaging of pathology in the neck, and that might help with the diagnosis. Is it always warranted? Not always. So I suppose it's warranted if there are red flags. It's warranted if they're older and you're kind of wanting to exclude the likes of temporal arteritis or whatever. If they're not complaining particularly of visual symptoms, they may not need to have their eyes specifically examined. And as I say, sometimes if you're in a fortunate position where they've responded really well to a nerve block, then that might give you a clue. Or if they're really struggling pain-wise, you might look at it as an adjunct to treatment, but it's not always available depending on where you see the patient. So we talked about our history taken and potential investigations. And I suppose baseline for most of us as physios, and I'm sure osteopaths are the same, are that we will conduct a thorough examination, and that includes, you know, a full neurological exam and cranial nerve examination as kind of standard. So when we look at a patient, I'm sure we're all the same, but it doesn't just start when they're sitting in the chair in front of us. We watch them and see how they walk in. We see what they're carrying, their willingness to take off their jacket, how they sit at you in the chair, whether they turn, whether they have to shift their chair. You know, all of this information is kind of giving us clues about what's going on. I mentioned there a full examination and neuro exam. But as well as that, we're going to look a bit more in detail about what's going on in the neck. And baseline for that is just plotting the range of movement. So some of us will use goniometers to measure that. Some of us will measure it in terms of range with quarter, full, or whatever. But what you're looking for is a difference between their affected side and their non-affected side. And as I said earlier, you're thinking of that restriction more on rotation on their affected side and probably flexion or a combination of both. So when we look at the neck, the first thing we do is probably look at their posture. So hands off and just have a good look. So when we think of a posture, we might think Do they have a forward head position where their chin's a bit more protruding? And I think it was Janda who first proposed the upper cross syndrome, where they will have weakness in their deep neck flexors, tightness in their pectoral muscles at the front, and they kind of come into this protruded position, and essentially what that's doing is compressing the upper cervical spine as well. So you're getting a bit of muscle imbalance, and you're getting a bit of compression in the facets in the upper cervical spine. That's not to be mixed up with normal age-related postural changes where, as we age, we lose a bit of disc height, we become slightly more kyphotic, but you're just having a good look and seeing what their baseline is. And also establishing what they do. So are they sedentary? Do they move? Do they have an occupation where they have to maintain sustained postures? Those kinds of things. And then when we look at palpating the cervical spine, so we talked about there that potentially new criteria for looking at cervicogenic headache might include palpation of the cervical spine. In physio and osteopath world, we might talk about it differently. So we label it as passive accessory intervertebral movements, or we palpate particular muscles. But essentially, we're all doing the same thing. So even if I think I'm doing a passive joint mobilization on C2, I'm probably having to go through some soft tissues to get there. So what we're looking for with those are if we see any reproduction or increase in their headache symptoms, or reverse, or how extensible the soft tissues are they tight, overactive, and does it refer pain anywhere else? Are they really stiff and they don't move, and you're kind of using your hands to determine whether one segment moves a bit more than the one beside it. But I suppose that takes a bit of experience and a bit of training. And then there are particular muscular trigger points that you might look out for. So if you'll get clues on that from their posture and where they describe their pain. So commonly it might be their upper traps or their levator scapula muscle, or even their sternomastoid muscle in the front. But sometimes you can see those things without putting your hands on people. And then there are some special tests that we look at as well for cervicogenic headache. So the key kind of special tests that we'll use are your cervical flexion and rotation tests. So essentially, it's looking at your C1, C2 articulation. And what you're doing is taking somebody passively into full flexion. So some people use it as a screening tool where they sit someone in the chair and just see if they can fully flex and rotate and whether it's limited. But actually, to do the test correctly, it should be completely passive. So the person should be supine. You should have the full weight of their head. You're taking them into full flexion, and then you're rotating and looking for end feel and comparing one side with the other. So the test is positive if you have a reduction of 10 degrees on the affected side. So it's positive for cervicogenic dysfunction at C1, C2. And it's been shown to be quite an accurate test in terms of being 85 to 91% accurate. So that's one that we'll do with all of our patients who we are considering cervicogenic headache for. And I suppose when you're taking somebody's head in your hands, they're quite vulnerable. So you're reassuring them. You're saying, I'm not going to do anything fast. If you can just let your head relax, I'm just going to do this slowly. And you're reassuring them as you do it so that they kind of get the confidence in what you're trying to do. And then the other tests that we look at there are looking at, the endurance in the deep neck flexors. And as I said, that kind of is born off the hypothesis that there might be a bit of weakness in the deep neck flexors, and that has been shown in some of the EMG studies that have been done. So there's kind of two different ways of doing this. So there's the hard way with a pressure manometer, where you're getting them to do cervical flexion, and you're incrementally increasing that until they change the pressure between 20 and 30 milligrams of mercury. But not everybody will have access to that. Some physios will, some physios won't. The alternative is where you can get someone to do a chin tuck hold, maybe ask them to hold their head an inch off the bed and seeing if they can maintain that position. So there's expected normal values for that in terms of women should be able to hold it for about 29 seconds and males about 39 seconds. And I think it's a really useful test to demonstrate to patients, actually, you know, your muscles aren't working quite properly here. But that's not a bad thing, because things are amenable to change with a bit of exercise, and it gives us a clue as to what exercise line will go down. So yeah, it's not until people try that test that they think, gosh, my head's really heavy, or I can't hold my head. So yeah, it can be a useful tool. So then moving on to management. So if we think this patient has cervicogenic headache, what do we do with them then? And really, it's a bit of a combination approach. So it might be advice. So that might be looking at some postural change. Now, not you must sit up straight all the time and never move, because that's not how we're designed to function. But just actually, if you're desk-based a lot during the day, then we have to look at what your ergonomic layout's like. Maybe you have to take more frequent breaks. Can we add in a lunchtime walk? Can we add in a bit of physical activity in the evening, just so you're not in those sustained postures all the time? It can include other things like looking at their sleep position if they find that that's a real trigger for them. And then, as with other headache disorders, you know, it might include advice around, you know, mitigating the amount of acute analgesia they're using, so that they don't end up with medication overuse headache in addition to what they're presenting with in terms of their neck. So the advice can kind of take a broad scope of things. It might even include, you know, stress management advice as well, if we think tension's a big part of the picture, and often in these patients it can be. And then as manual therapists, I mean, it's kind of fundamental to what we do. So if our examination has shown that they are stiff, tight, then we might explore different types of manual therapy for that. And I suppose there's a whole range out there, and that's kind of what we specialize in. So we pick and choose depending on the patient. And then also, there's very few people that come through the door that you wouldn't be encouraging to do some kind of exercise adjustment if you've seen that they're stiff, weak, have poor control of their head, and your assessment will dictate what type of exercise you do. So when we use the term manual therapy, sometimes that's like voodoo for people who don't touch patients, but essentially it's a combination of techniques that look at skilled hand movements to improve things like tissue extensibility, increase the range of movement, mobilize or manipulate soft tissues and joints. And what we're trying to do is modulate pain, modulate inflammation, improve restricted movement. And as I say, it includes a range of techniques. So that can include things like joint mobilizations, which are small velocity, low amplitude movements, joint manipulation, probably a bit less commonly, but it is a potential option. Mobilizations with movement, massage that people would be familiar with, some trigger point therapy, or might just put our hands on and try and help somebody with some stretching. So it's a combination of all of those things. It's not for everyone, so there's certainly groups of people that we wouldn't be keen to do that for. And that includes people who have obviously significant trauma with dislocation, fracture, if they've had ligamentous disruption, even thinking about instability with some of the RA and Anki-Spawn patients. And I have had patients being referred for physiotherapy who have had things like dissections, and you don't want to touch them. So those are not the patients to send to physiotherapy for manual therapy. It doesn't mean we can't do anything, but it's probably a hands-off approach. And obviously there are people there that would be a bit careful with. So as I mentioned there, exercise is a big component of what we do from a physiotherapy perspective, and the world's your oyster in terms of what that can look like. So it's definitely not the same for everyone that comes through the door. For a lot of patients, we are chatting to them about general physical activity and what works for them in terms of trying to get them just moving. And there's definitely research to say that some movement is better than no movement. So if they find something that they can stick to and they enjoy, well, that is worth its weight in gold, and certainly to be encouraged. And then there might be kind of a bit more holistic exercises that you would suggest. So things like maybe yoga that might have some flexibility component, but you're also building in the relaxation element. And you'd be surprised, a lot of patients, when you suggest yoga to them, you think they're like, no way. And then you might show them a video and they go, oh, actually, I think I could do that. Or you try it out with them and then they're kind of reassured. But sometimes it's about getting your foot in the door and just trying it to see. And I suppose other things that sit in that camp there are things like Tai Chi, where you're getting just that general relaxation effect as well. And then I mentioned as well, you know, looking at more tailored exercises. So depending on what your assessment has found, you might determine that somebody has poor motor control around their head, and sometimes they've got chronic headache. They just have no idea how their head moves, and they've really poor control. So yes, while you might do a bit of strengthening, you might add in a bit of a balance component and those kinds of things, as I say, depending on what you find. And I put that picture in there because you know, tying a band onto somebody's head is what I determine with my patients is our ninja exercises, and warn them that they're going to look stupid, but sure, it's a bit of crack and they'll do it anyway. And when you kind of explain it in a way to a patient where you're saying, do you know, if you're wanting to get your bicep a bit stronger, you'd start to add on a bit of resistance. Well, actually, we want to get your neck a bit stronger, and I'm not tying a weight to your head, so we're going to use this band. And then they tend to come around a wee bit as well. It's often a hit with the grandchildren, just to say, but to be kept away from dogs. So those are the kinds of things that we offer. Now, that's not the be all and end all. So whilst manual therapy, postural re-education and exercise are the mainstay of what we do, sometimes we need to explore other things, and that might include things like relaxation strategies. Some might do biofeedback. There are some patients for which I would do acupuncture for cervicogenic headache and have had reasonable effect with that. If they're too sore to put your hands on and aren't tolerating a lot of manual therapy, you might consider a nerve block if you have it available, or you might suggest some medication if you're a prescriber, or send them in the direction of their GP or neurologist, depending on where they came to you from. In my experience, sometimes things like amitriptyline can be useful if they're also having difficulty with sleep. But as we heard in the previous talk, you know, if you're getting somebody who has low mood or are really anxious, have headache, and you can see that they're really tense, well, then propranolol might be indicated. But it really it depends on the patient. So I suppose that's all I was going to say in terms of the assessment and management of cervicogenic headache, but I'm just going to pass over to Liz, who's going to chat a little bit about some ongoing cervical drivers.
Okay, good evening. Hello, thank you very much, Sonia. Thank you, Ben, for inviting us to do this. My part is quite short. We've just got 5 slides just for the last 5 minutes of the presentation. And we're going to look at spend a little time looking at the overlap. So in a clinical setting, patients often present with overlapping features of several headache phenotypes. In this 5 minutes, we're going to introduce an example of this with the potential cervical elements in some migraine patients. Is this something we should consider in clinical practice and research? Is there any supporting science? What would be the underlying mechanism and how could it be assessed? So let's start with why this is important. Because it is a patient experience that head and neck often come together. Studies show 90% of migraineurs report having neck pain. Indeed, this may well be the reason why in the 2012 study of patients attending NHS tertiary headache clinics, up to 20% of patients had previously visited osteopaths, with similar numbers seeing physiotherapists and chiropractors. The National Council of Osteopathic Research 2019 audit showed 9% of patients visiting osteopaths in the UK do so complaining of head and face pain. This amounts to 3,000 consultations a day, and that's outside the mainstream framework, health framework. This patient experience means manual therapists are a popular choice for migraine patients, but to what effect is uncertain. Migraine is a neurovascular condition driven by the CNS, but is there evidence that for some migraine patients, there may be a significant driver, peripheral driver from the cervical spine? So what does the science say? Well, Kirsten Ludke and Anna May did a study in 2017 looking at whether migraine patients could be stratified into subgroups based on provocation tests applied to the upper cervical spine. They took 179 migraineurs and in an interictal phase palpated the structures shown in the diagram. They found pain provocation in the upper cervical spine was significantly more prevalent in patients with migraine than in headache-free participants, and stratified the sample into 3 subgroups: 11% pain-free, 42% local pain only, and 47% pain referred to the head. Studies done in Australia, done by Watson and Drummond, have taken one step further and looked at pain reproduction, head pain reproduction, and resolution. They found in some patients, head pains could be reproduced with pressure applied to structures in the upper cervical spine, and then by sustaining pressure for between 5 to 20 seconds, the head pain would resolve. This, they suggest, implies a noxious cervical afferent input may be significant and may drive or perpetuate a susceptibility to migraine in some patients. Here is a simplified diagram of this hypothesis. On the left, we have episodic migraine without aura. In this case, the main driver is the CNS, and the attack itself leads to allodynia and hypersensitivity in the structures of the head, neck, and shoulders via the trigeminal cervical complex. When the migraine attack is over, these symptoms disappear. And then in green, the cervicogenic headache, as we've just heard, conditions or pathologies of the cervical spine lead to head pain through nociceptive pathways, also via the TCC. And lastly, on the right, is it possible that they could overlap? In the chronic migraine patient, could recurrent attacks lead to tissue changes in the neck, which in turn create a persistent, noxious output contributing to a state of sensitization? Now, whether peripheral tissues such as joints or muscles can indeed trigger migraine attacks and or contribute to the transition from episodic to chronic migraine remains to be investigated. But if confirmed, it would be essential to detect and treat these musculoskeletal dysfunctions appropriately and reduce incoming nociceptive signals. It has therefore been proposed to include a manual joint examination by a skilled pair of hands into the routine physical examination procedure of migraine patients, and to use both components of the test, that's palpation and sustained pressure, in a combination to reach a high specificity and sensitivity. So the take-home messages: should we consider migraine with cervical element as a subtype, with a cervical element as a subtype? And if this upper cervical spine is a potential sensitizer or driver, should it be identified by a skilled pair of hands? And consider treatments to reduce this ongoing cervical afferent nociceptive input into the TCC complex, such as we've just described, manual therapy, acupuncture, or gum blocks or medications. So that was just a brief introduction, or to just 5 minutes. That's all I have to say. I'm sure everybody's had a long day, so thank you very much for your time. But we just wanted to include that potential drivers in with the cervicogenic headache presentation. So thank you very much.
Thank you very much. That was excellent. I'd like to thank Sonia and Liz for delivering that excellent talk on cervicogenic headache. It's a big area and it's something that we all encounter in complex headache clinics. Just while I'm waiting for the questions, I'm just going to recheck my posture because I know that's one of the themes of today. I just wanted to ask, do you ever see patients that have very postural headache where we think it's actually coming from the neck? So in other words, patients that present as though they've got intracranial hypotension, but actually it's coming from the neck. And what could an explanation for this be, possibly?
Is that for me or for Sonia?
That's for either of you.
Okay. Well, I think there's a difference between, I'll take that first, orthostatic headache, which will be the difference whether you're lying down or standing up. So I think that can differentiate it from just whether you're posturally, whether you've got an extension. Sometimes when people lie down and they get an extension in the cervical spine, it can happen at the same time. But I think with a good assessment, you can try and differentiate between the two. Does that answer the question?
Well, I'm just wondering, I've got a few patients that have very, clinically you think they'd have intracranial hypotension, but when you investigate them, they don't. And I always then defer to the neck and give them a trial with the soft collar to support the neck to see what's going on. I don't know if you've had similar patients at all.
I would be less inclined to give anyone a soft collar just in terms of, reducing their strength, and that might be adding to some of their ongoing issues if you're then taking away what supporting structures they have. So I suppose I'm not a fan of collars. That's what I would say.
Just one waiting because we've only got 2 questions. What role do you think MRI scans have in assessing patients with cervicogenic headache? Do you think it's useful or only useful in younger people, bearing in mind that the majority of people over the age of 40, like me, would have some wear and tear in their necks?
Yeah, I suppose in my experience, it's useful if there are the presence of red flags, but if you can influence their symptoms without it and you're fairly certain they're in a cervicogenic camp, they have reduced range of movement, then I don't really think it's indicated. Because on the flip side, sometimes you'll get patients coming in who say, and they own the diagnosis that was on the MRI report, whereas they don't have any signs of nerve root compression or anything like that, no stenosis, but they're reporting to you what they have been told from what's on the report. And actually, when you put it in the context of actually a lot of people in your age group are going to show those signs, it's not necessarily a cause of your symptoms. I think you have to be delicate about how you approach the conversation with the patient, but I would say useful in the presence of red flags, or if you suspect that the patient might need orthopedic input, so that if they have rip-roaring nerve root signs where they've got weakness, loss of reflexes, and you think they're going to have to see your orthopedic colleagues, well then yes, but in the absence of that, it's not always indicated.
Okay, brilliant. I've got a question here. How do you differentiate between neck tightness that might be due to prodromal symptoms of migraine attack versus cervicogenic component driving migraine instead? So it's a classic chicken and egg scenario. Is it coming from the neck and causing migraine, or is it the migraine causing the neck pain?
So suppose if you're fortunate, and say fortunate in that it's an episodic migraine picture, and that's the only time that they get it, and then they go long spells where they're not having any neck symptoms, you might think, well, it sits more with if it's coming prior to their migraine and then they've got all the other migraine features, then I'd be thinking, well, it's probably migraine. And then I would also sit with, are there those mechanical ags and eases? And to be honest, there's some patients that you're not 100% sure with, and the way that I sell it is, look, well, if there's anything there that's amenable to change, let's see if optimizing the neck makes a difference to your symptoms, because often when you put it to patients, they're keen to explore non-drug options. You know, I say to them, you know, the worst you could come away with here is a stronger, more mobile neck and no change in your headache. And then they're willing to try. So sometimes it's about how you package it to the patients. I'm not sure if you have any other words of wisdom there, Liz, in terms of that one.
No, I agree totally with what you say. I think it's interesting, the studies that I mentioned in the last 5 slides. I think it's quite useful to be able to differentiate and have some kind of examination and tests, and if you can reproduce the pain, any head pain with provocation or reproduction tests. But when it comes to again, neck tightness, it's a constant question everybody's asking: is it top down or is it bottom up? Is it just bidirectional and self-sustaining? So you change what you can change easily, keep it simple. You manage patients' expectations. So you're not promising or leading them, you know, that making them think it's all in the neck when it could be top down. And then together in partnership, you go ahead and you change what you can change simply with the treatment, and then see how they respond.
Okay, just a couple of more questions. How often do you trigger migraine attacks or the auras of migraine when you manipulate people's necks?
I think there's a reasonable anecdotal evidence. I don't know if there's any studies to show this, but I think it depends what you call by manipulate. If you're talking about quite high velocity thrusts, which people often think about, which is the clicking or the cracking of the neck, then I think there's reasonable anecdotal evidence that if you've got a migraine patient, you may not want to do that anyway, because it's not much evidence suggests it's going to be effective, but it will. I think anything that puts a lot of input into a sensitized neck will have the chance of triggering a migraine afterwards. What is that your experience, Sonia?
Yeah, and I suppose, again, just in that context, you might reassure the patient and say, look, we're trying to influence what's going on here. So you might find that this does trigger attack. If it does, you let me know, and then we base our future treatments around that. So if it's too significant, too sustained, worse than their normal, well, then you might not explore that. You know, you might change the direction of your treatment. But again, if you've been pre-warned that it might happen as a consequence of what you're doing, and then you kind of want them to clock, right, well, okay, if it caused an attack, it's hard to say if they're chronic that it wasn't coming anyway, you know, but you want to know after that if they're getting any change down the line. So that's when your headache diaries are really useful, so you can see if you're influencing it over time.
Right, okay. Last question. How useful are heat or ice packs in problems with the neck? Recommend them or not?
I recommend them. Patients ask which is better, cold or heat. I say whichever you prefer is better. I mean, if you've got somebody with an inflammatory condition, I'd probably go down the ice line. But if you think about somebody who's tight and sore, they often prefer a bit of heat. So it's really whatever they tolerate. And you're just giving them a bit of advice about not putting it directly under their skin and for how long they should keep it on for. But it's safe. It has no side effects. It's not going to make their hair fall out. So I'm a keen advocate of those things. And, you know, if they can use those things as an adjunct to what you're doing, then it probably works quite well.
Brilliant. Okay, well, I'd like to draw this webinar to an end now. I'd like to thank our speakers again, James, Sonia, and Elizabeth, for giving up their time this evening to talk about traumatic brain injury related headaches and cervicogenic headache. And if anyone has any more questions, they can direct them towards me, and then I will send them on to the speakers this evening. Thank you very much, everyone, and have a very good evening.
Thank you.
Thanks very much. Pleasure to talk. Bye.
Thank you.